Good afternoon, everyone. Can you hear? Yes, I can hear that a bit better. It's like lecturing in a farmyard with noises going on all over the place. So it's very good to have the opportunity to talk to you today, particularly in the context of the wonderful GDE stand and activity that we're seeing over here. And what I want to talk to you about is the importance, really, of clinical leadership and how that ties up very closely with implementation and patient safety. Now, the previous regime, if we can call it that, were very clear that the outcome of the contracts that they were commissioning were going to be judged very heavily on the quality of the outcome. And there are three dimensions to that quality. Basically, what is the patient outcome? What is the patient experience of going through all this? And what are the patient safety implications of the processes and procedures that they've had to go through? Now, this is truly an Escherine triangle, because given the variability of people, both the carers and the patients, it's very difficult to understand sometimes where safety ends and the clinical outcome begins, and how patients would interpret that as the quality of an experience that they've had to go through. So here are a few fairly sobering statistics. When the CQC did their round in 2015, and the 16 report is not yet available, they found that there was a huge amount of inadequate care in the hospitals. A large number required considerable improvement. 7% were indeed rated as completely inadequate in terms of their performance. And probably the most worrying thing of all is the amount of variation that there was in outcome with healthcare delivered. And now, when you compare that against the other industries that we're familiar with, those that we understand to be dangerous, then the nuclear norm is about 1 in 100,000 incidents. And in aviation, if they get more than 1 in 10,000, then it's a very worrying trend. But year on year, for a variety of reasons, mostly because of inspection and because of the ethos of no blame, these are all improving year on year on year. Now, where's medicine in all this? At the moment, the statistics are that we have about 1 in 10 adverse incidents for every hospital admission, which is a shocking tale, really. So what are we going to be able to do about that? And how will digitization and clinical leadership be able to affect that? Now, I mentioned earlier that we have a very interesting variation in the nature of people. And when we look at patients, and this is a survey done by the Department of Health, as it was then, we have, can we see it? No, can't see it. Those at the top who take a very serious view of what their health is, and the bottom end of that is, I'm not worrying about my health, it's just going to look after itself. And on the left axis, we've got illness is a fact, we just have to accept it, we know we're going to do something about it. And the other is, illness is a failure, I don't want to even contemplate it and I'm not going to do anything about it. So in the top left quadrant, we've got those patients who are very willing to accept screening, counselling, advice of all sorts. And on the bottom right, we've got those who present themselves in accident and emergency with the large tumour in their abdomen that they've been quietly ignoring for the last 3 or 4 years. Top right, we've got the sweaty trainer brigade, and need I go on? So the variability is quite enormous. Therefore, their reported experience of what they go through, it very much depends upon their personality. And if we have a similar look at the clinical organisation that is delivering their healthcare, these, I'm sure, will chime with anyone who's worked in a hospital. We have those who've got a very strong grip on reality, and the enthusiastic pragmatists, the Tiggers of this world, who on the top right axis there. The bottom left, we've got the Eeyores, those for whom everything will be wrong and nothing can ever be done to correct it. So even amongst those who deliver the healthcare, the interpretation of a single event is going to be very, very variable. Now, that sounds a little trite and a little easy, but there is actually science behind this. And when you look at a rather more detailed way at the professional subcultures at work inside a healthcare organization, it's very, very interesting. We've heard of the doctor-manager split and their attitudes to healthcare, and here is a very good way of looking at it. If you imagine that one group is going to look very hard at accountability and being transparent about outcomes, and at the bottom end, we've got I'm the clinician here, I know what I'm doing, I know it's right, just leave me to get on with it, then you can plot, even on an international scale, the way that nurses, doctors, and managers sit on this paradigm. And it's absolutely repeatable, and we can see it everywhere. Now, that might sound a little fatalistic, and it might sound as if there's nothing you can do about it, but in fact, the lessons are really quite interesting. It's readily identifiable as a tribal thing. We've all come across that, I'm sure, in our hospitals. The mere fact that it is so repeatable, there is some comfortable there. It is also predictable, so you know you're going to come across these attitudes when you go into a healthcare organisation, and it works as well in primary care as it does in secondary, and it also works in commissioning organisations. But the best bit of it all is, since you know where you're coming from, you can construct a reasoned argument to be able to counter what's going on. So when you're faced with this apparent infinite variability and rather tribal nature of the way the world works, what on earth are we going to be able to do about it now? So the key factors which will affect the success of healthcare transformation and its subsequent digitization in a big organization are these. Firstly, the top end of the organization, the board, must be openly enthusiastic and absolutely visible when it comes to doing it. They must be there, they must be in amongst it, and I dare say we've all come across hospital boards where you never even see the executive layer. It's the C-suite, it's tucked away on the far side of the campus, and you never come across them. But if that happens, it means that the implementation of complex systems like this is going to be very, very difficult. The next most important factor is that the people who work in the organization must be absolutely committed to the notion that they might need to change the way they behave. If we look at the model in which healthcare is currently delivered, you will see that in Victorian times. It's no different, really, and it's very much organizationally focused, and it's focused about the people who deliver it, but not the people who need it. And the final thing is a willingness to embrace disruptive technologies. Now, what do I mean by that? For example, we've all heard of 111. I dare say there's nobody here who hasn't heard of that. The GPs absolutely hated that when it was brought about because it allowed a patient to pick up a phone, get good clinical advice without actually going anywhere. And it was seen as undermining professional values, and because it wasn't their idea, they thought it was dangerous. But it has been shown time and time again that with a good, timely telephonic intervention with qualified clinical advice at the end of the line, the outcome is extremely good. And those of you who hopefully listened to Matthew Swindell's this morning will understand that it's this frame shift, it's this mental ability to say, I'm quite prepared to change the way I deliver healthcare and then support it with a suitable technology after that, that will enable us to get the efficiencies that we are going to need if healthcare as it currently stands is going to survive. Now, here is the way that previously we have seen focuses of healthcare informatics. They are very, very much focused on organizations rather than the place at which the illness occurs. And as we heard this morning, what happens to a fit worker who cannot afford to take time off when he can't get, or she cannot get, to go and see a GP because they're shut before they go to work and they're shut after? And the net effect of that is healthcare is denied. They don't do it. They don't go. They become more ill and the outcomes are worse. What we need to be able to do is change the way that we look at this and say, rather than be organization focused, we must be needs-based. We must support the person who's busy. We must support the mother who can't leave home. We must support the disabled because they just cannot get about. And above all, we must empty the inappropriate patients from those places where they are clogging up access and the availability of healthcare. there is another factor too that I think is worth considering. We are now in such a technically advanced age that we have 3-parent babies, we have designer genomes, and what we are capable of doing has begun to blind us to really what we should be doing. The sophistication of it all has hijacked our imagination to the point where we fail to see that we should be using the technology to look at simple things, not always the very difficult and the very advanced. So implicit in this again is the willingness to understand that we have to change the way we work and then embrace the technologies to support that once we've decided the most efficient way that we should do it. All of this is critically dependent on leadership, because we know that the way healthcare is delivered is by a group of people who are professionally by nature very conservative. It's managed by a set of people who have got a very difficult time trying to account for what they're doing. And we have a set of patients who like to understand who their doctor is. So how are we going to break all these traditional ways of behaving so that we can start constructing it in an altogether different way? The key to all this is going to be the nature of the leadership that we use. Now, leadership has developed quite considerably over the last 30, 40 years to the point where we've gone from the enormously heroic on the one side to the far end of the scale where we're beginning to say, well, let's look at those who are very good at changing things quietly. The heroic side is, there, look, I did that for you, look at the results. And the transformational side is saying, I'm not here to do this for you, but what I am going to do is help you change the way you do it so you can do it for yourselves. And there's been a sort of gradual transformation of leadership development and thought to begin that ability to be transferred from one person to the next. Rather than being born a hero, sitting on a white horse, you can actually be, through suitable learning, turned into an extremely capable transformational leader. Here's a few fairly notable leaders that we've come across in our time. And the geographic proximity of the ones on the right is probably no accident. But you can see in amongst that set of pictures the various natures that I've just described to you, those who are transformational and those who think they are heroic, and above all, those who think that this is the way to do it, because that's the way they've always been taught. And unfortunately, there's much in the NHS at the moment, particularly from the managerial perspective, where they dare not transit out of what they currently do because at least that's been proven to be safe and you can survive it. So, we've lost the top of the slide there. The nature of the leadership, this is the way in which the transformation has happened, in that the modern transformational leader looks at social movement above all, and this is an academic piece of work led by Paul Bate, and this has shown that if you're going to make transformational change and actually produce statistically meaningful results, it is a distributed function. It's done at all levels of the organization. It's done by people who are as prepared to follow as they are to lead, but above all, they are prepared to listen and to show by example. All that being said, the reality of trying to do it is that you inevitably meet some kind of resistance to some entrenched behavior somewhere. And so this is the kind of pattern that you will always find when you're taking people on the journey that you want them to go. Telling them about it is quite difficult, and that takes time. Beginning to move them means you usually encounter resistance. Well, they're halfway there, they're grudging, a little bit grumpy, but they begin to see what you're talking about. After that, they say, well, yes, perhaps it was my idea anyway. And they're able to enthuse a little more about it. And then when you're really lucky, you'll find the people that you found so difficult to move actually become your champions themselves and help you on that journey. So in that we are talking about digitization, what are the characteristics of the systems that we're going to be seeing that will help us adopt this transformational process and to move people from their entrenched positions? The truth of it is, a good information system is a tool, and it's just like a spade or a lawnmower or a car. It's going to enable people to do a job which is bigger than the one that they currently do or they think they are currently qualified to do. Now that in itself is a fairly threatening paradigm to the various professions who think one particular job is my job, it's not anybody else's, and I resent the fact that less qualified people are saying that they are as able to do it as I am. So inevitably, the introduction of systems like this will produce a resistance because it threatens professional stability. But on the other side of the coin, the patients for whom we are really here have got a completely different view of it. They're saying, I want to be much more involved. I want to understand the process that you're telling me to go through, and I want to understand why, and I want to understand how the decisions were made and the basis on which they were made and the data that is being held about me. So we have this rather awkward standoff, or at least historically we did. But then this morning we heard the light bulb moment when even the department are saying the data belongs to the patient. And that is a real frame shift. Also, these systems have got to be able to support national and local ways of working. We all know that the different places that we've worked in, and I speak as an NHS professional lately, the culture of the place that you work in has a very, very strong effect on the way things are done in that organisation. Therefore, accommodating locality variation is going to be an important part of success, because you can't ignore the fact that it works there, it works for those people, and their desires must be accommodated to some degree. Similarly, the systems that we use now must be able to record where we were so that we can show that there's been a meaningful change for the better when we actually deploy them and use these systems in our day-to-day work. Embarking on this feels a bit like this. You can tap the elephant on the back. It takes 3 seconds for that tap to hit the brain, and even longer for it to turn around and look at you. And that's what it feels like when you're trying to do this kind of thing to the NHS. It takes a very long time. Lord Carter, who did the recent review of the health service and efficiency, has done a lot of reviews for government, and he says it takes 7 years between starting it and the effect of the report that he wrote on the organisation itself for the better. A 7-year time lag. And that's a pretty instructive statistic. So it's worth keeping trying. It feels like you're dealing with an immovable object, but actually you're not. So what are the characteristics of a clinical leader? It begins with the 3 A's, really. The clinical leader must be affable, must be perfectly personable, not dismissive, be able to accommodate all kinds of points of view. They must be demonstrably able, that is to say they have a clinical track record which gives them credibility. They have the social intelligence to understand what's going on around them. And above all, they have to be available, that is to say they have to be seen, they have to be walking around, they have to be seen to join in and to lead by example whatever's going on. So they know that it's most important to put safety right at the front of clinical practice. They understand that the technology is not there for its own sake. The technology is only there to support the best possible process that you can design for your patients. They understand that all of this is meaningless unless you can compare where you were to where you are now and how there is a benefit. They have the social intelligence to understand leadership styles, and above all, they are capable of following as well as they are of leading. In fact, when you look around the NHS, there are plenty of examples of good practice where areas have transformed the way they work, where they've used digitization to support that, and where they have the kind of clinical leadership to enable this to stick and to be seen to be a benefit. It's just, it's not evenly distributed. Thank you very much. Any questions? I want to keep you from your gin and tonics. Well, good evening, everybody, and thank you very much for attending.